Multiple myeloma is malignancy of the plasma cell. Multiple myeloma is excessive plasma cell proliferation which produces excessive gamma globulin or immunoglobulin, which is called M protein. Multiple myeloma is diagnosed on the basis of serum M protein greater than 3 gram per deciliter, urinary M protein greater than 500 milligram per 24 hours, clonal plasma cell in bone marrow greater than 10% and less than 60%, plus one or more feature of myeloma defining events such as end organ damage or any of the biomarkers of malignancy. End organ damage is detected by the following features such as serum calcium greater than 11 milligram per deciliter, renal insufficiency, which is detected by serum creatinine greater than 2 milligram per deciliter, hemoglobin level less than 10 gram per deciliter, and bony lytic lesion. Biomarkers of malignancy are clonal plasma cell at bone marrow greater than 60%, serum involved and uninvolved free light chain ratio greater than or equal 100, and bony focal lesion greater than 1, which is detected by MRI. Smoldering multiple myeloma is defined by serum M protein greater than 3 gram per deciliter, urinary M protein greater than 500 milligram per 24 hours, clonal plasma cell in bone marrow greater than 10%, and there is no evidence of organ damage and no feature of malignancy. And there is another condition which is called monoclonal gammopathy of unknown significance, which is defined by serum M protein less than 3 gram per deciliter, urinary M protein less than 500 milligram per 24 hours, and clonal plasma cell in bone marrow less than 10%. Patients suffering from multiple myeloma usually comes with the following symptoms: bone pain and fracture, anemia due to decreased hemoglobin synthesis, abnormal bleeding from the nose and hematuria due to platelet defect, fever due to defective immune system, polyurea, which is a feature of hypercalcemia, constipation, which is from hypercalcemia, nausea and vomiting from renal insufficiency, and edema from renal insufficiency. To diagnose multiple myeloma, following investigations are done: complete blood count and peripheral blood film to see hemoglobin level and any blood cell defect or any blastic cells, serum calcium, which is usually raised due to bone destruction, and calcium efflux, serum creatinine, which is raised in renal insufficiency, serum protein electrophoresis to detect immunoglobulin, 24 hours urine study for proteinuria and electrophoresis, bone marrow study to see the clonal plasma cells, and imaging study to detect any lytic lesion. Lytic lesion greater than 5 mm is disease defining. Management of multiple myeloma. Multiple myeloma is not 100% curable. We use chemotherapy to hold the progression of the disease. Common chemotherapeutics are cyclophosphamide, doxorubicin, etoposide, melphalan, vincristine. We also use targeted therapy to destroy the cancerous cell. Those are lenalidomide, bromalidomide, thalidomide. We also use steroid to decrease the side effect of the chemotherapeutics. Commonly used steroids are dexamethasone, prednisolone. We also use monoclonal antibody such as daratumumab, elotuzumab. We also use proteasome inhibitor such as bortezomib, carfilzomib, ixazomib. We also advise for stem cell transplant. Chemotherapeutics are usually used in combination. Some commonly used chemotherapy regimen are bortezomib, cyclophosphamide, dexamethasone combination. Others are bortezomib, lenalidomide, dexamethasone, and daratumumab, lenalidomide, bortezomib, dexamethasone. And previously, if the patient is previously treated, then this combination may be used. Bortezomib, lenalidomide, dexamethasone. The combination may be cyclophosphamide, lenalidomide, dexamethasone. Latest FDA approved chemotherapeutics combination is daratumumab, hyaluronidase, carfilzomib, dexamethasone. Management of bone pain and complication. To reduce the bone pain and bone fracture, we sometimes use bisphosphonates such as alendronic acid, zoledronic acid. We also use radiotherapy to manage excessive bone pain.